a packed agenda. So a few years ago, we did a variant of this. This is a continuation of two of three sessions that we are focusing on departmental research and specifically research opportunities, mainly for our house staff, but we've also invited our surgical interest group of medical students to listen in on these as well. So from my perspective, this is really an opportunity for us to learn and to hear about all the great things that are going on within the Department of Surgery as research opportunities. We have decided this time, rather than going to individual investigators, we were going to break it up in terms of the major academic divisions or programs within the department, because right now we know, particularly for the more junior residents, you may know you want to be a vascular surgeon or a thoracic surgeon, but you're not that far into what kind of research you want to do. So this will let you get an overview. Eric, do you want to serve as the master of ceremonies for this, or do you want me to do the introduction?
Sure, I'm happy to do that. Thank you, Keith, for the opportunity for us to all hear from each division and center. I think in our roles, it's really to build bridges. And last week we heard from Jordan and Taylor about our career development plan for the trainees. So we're very excited then to now hear from the many opportunities that abound in our department for these different research efforts. So today we'll be hearing from thoracic surgery, cardiac surgery, vascular surgery, surgical oncology, general surgery, and a combination of different investigators working on health services research and disparities research. And next week we'll hear from other divisions that we'll send out the flyer about. And Justin, you have control of the slides. I think, is it cardiac or thoracic that's going to go first?
It says thoracic on my agenda. So Yolanda.
It's us. So to everyone on the call, I really want to say thank you. I'm very excited about talking about what our overview of our research is within the Division of Thoracic Surgery. And this talk is really dedicated to all the residents and medical students who we've worked with before, who've done such a great job at bringing our research along. And it is aimed particularly at all those future trainees and mentees and research colleagues that we are talking to in the audience. So next slide. So we have a lot of research interests in our division. I've tried to bring them all together as a theme. We are committed to both basic and translational research to really answer those key questions that we think impact the lives of our thoracic surgical patients. And we also are very committed to clinical research focuses on those outcomes of patients: lung, esophageal, tracheal cancers, tracheal stenoses, benign esophageal disease, mediastinal masses, and thoracic outlet syndrome. And you'll see we talk about all these different things that we do. Next slide. So we want you to help us fight the top cancer killers in the world. If you have any interest in cancer, this is a place to come. There's 1 in 5 people in the US who have lung cancer. Lung cancer kills twice as many people, women, as breast cancer, 3 times as many men as prostate cancers, and in fact, more women than breast, ovarian, and uterine combined. Only 5 to 30% of patients survive at least 5 years after an esophageal cancer diagnosis, and almost 19,000 adults are diagnosed with esophageal cancer in the United States. And it is a place where we can make a difference. Go. These are your future mentors. I think they look like a very friendly, pretty good looking group. So I think you should really think about it. Next. We want you to join us in investigating these clinical trials. We have trials looking at tracheal stenosis, both idiopathic and post-intubation after COVID-19, cancer recurrence after surgical resection, looking at polymer drug delivery, registry of ground glass opacities. These are lung cancers that women get that we don't know very much about. We want to have you help us look at using wearable technologies, which can predict and detect postoperative complications and outcomes of minimally invasive lung surgery and esophagectomies. Next. We have some very pioneering basic thoracic research. We have the 3D organoids and metabolomics that Uma Sachdeva is doing. You can click on this one. And here, as everyone probably already knows, OTT has some amazing stuff on lung regeneration and building new lungs. We have nanoparticles and polymer meshes to prevent nodal and local recurrence, keeping tumor cells from going to the lymph nodes. Next. And we have translational thoracic clinical trials. We have preliminary evaluation of new markers to look at colobrite in healthy individuals, in lung cancer patients with radiation therapy, and pulmonary fibrosis patients, looking at the pulmonary fibrosis. We have pilot studies in implanting microdevices within patients, looking at drug responses in situ within lung lesions. And we have new trials coming out as near-infrared perfusion, looking at minimally invasive thoracic surgery and perfusion of the esophagus and esophagectomies. Next, or the conduit rather. Here's the near-infrared guided lesion localization, where we actually are looking at the near-infrared marking. So I think you can go ahead and do that, Justin. Whoop. And what you see is it allows us to actually go down the airway with a bronchoscope. You can see this lesion that you can't find normally intraoperatively. And we'll go down and using navigational bronchoscopy can go down and find the lesion, and we put dye at that lesion itself. That allows us to identify where the drainage patterns are to lymph nodes. And you can see the actual lymphatic mapping when we get an actual marking. And then by identifying where that lymph node, where that tract goes to, identify the lymph node. And you can see when we open this up that we see green lymph nodes. And now we're starting to study what is it about different lymph nodes. And we've been able to show that by finding that, you can predict the likelihood of recurrence. Next slide. So translational research, we have mixed reality platforms to improve intraoperative planning, patient-derived 3D organoids, as I showed you of UMA's, the esophageal cancer, and looking at chemoradiation susceptibilities, oncolytic viral gene therapy and oral antihypertensive medicines to improve treatment of locally advanced lung cancer, tissue engineering, whole organ regeneration, and xenograft transplantation and organ tolerance. Next. There are several thoracic clinical trials that you should really think about what are interesting. Nick Panda is looking at harnessing the smartphone for improving decision-making and health-related quality of life. We have phase 3 trials looking at neoadjuvant treatments, which have made profound differences in how we're treating lung cancers now with Mike Lanuti. Next. We also have PET imaging of radiation-induced lung therapies and using wearable technology to improve outcomes in older thoracic surgical patients with our new recruit, Dr. Yang. Next. Clinical research, we have much. Analyzing outcomes and treatments in esophageal cancer to look at patient outcomes. Comparative effectiveness research in thoracic oncology, both multi-center and national. Outcomes in thoracic outlet syndrome, looking at analysis of thoracic surgical outcomes with the STS database, and outcomes following pulmonary thromboendarterectomy with CamRight. We're looking into artificial intelligence in terms of robotic thoracic surgery with Lana Schumacher, who's also a new recruit who you may not have yet met. Tracheal stenosis and reconstruction, both with Harold Ott, as I mentioned before, and also Drs. Wright and Mathieson. And then hyperhidrosis database outcome studies with Dr. Allen. Next. We want you to help us publish on all these different topics. These are all things that are really important to us. You can see different topics in different areas. Next. And these are the journals that you could publish in. We have articles in all of these. We've gone everywhere from biomaterials, nature reviews, translational medicine. We're very active in publishing in a variety of different places, and you're connected into thoracic surgery. And even if you don't want to do thoracic surgery, it's still interesting questions. Next. So the other thing is to think about, what are the awards when people work with us? What do they do? These are some of the awards that residents have actually achieved while working in our labs and working on these projects. It's a very active funding environment, and it is very good to be seen. Next. So I want you to join us. I want you to email any of the thoracic surgeons on any of the projects that I talked about. You can talk to me, you can email me, you can get a mentoring meeting. Let's find out what fits your career. You can call my administrative assistant at that number and just say, I just want to see the labs. I want to talk to any surgeon. Tell her the name. We'll make it happen because we are committed to your career. We love the people who work in our labs, and we really want to help you guys find a way. And I know we have limited time, so that's why it's so fast, but you can find us.
Terrific. Thank you, Dr. Colson. That was really a tremendous overview. You know, we talked about last week that the surgeon scientist is live and well at the Mass General, and certainly your group to the faculty member, everyone, congratulations. Really astounding work. You've made it so easy for all the trainees and students to get in touch with you and your group. So thank you so much. Next, we're here from cardiac surgery.
Thanks very much. Now I've been feeling my mortality since my birthday last month, and now that I know that 1 in 5 of us is going to have cancer, I'm even more frightened. But be that as it may, we'll take this opportunity to talk about some of the things that are going on in the Division of Cardiac Surgery. Next slide, yeah. And we'll talk about some basic science research, some device design and innovation, clinical trials, and then the Outcomes Fellowship. Next. So we're fortunate to have Robin Pearson in our division. He does clinical work principally in the intensive care unit, but of course is part of the transplantation biology effort and is also a leading figure in xenotransplantation internationally. He and his team are doing work in heart as well as lung xenotransplantation. There's also exciting work that you've heard about from the transplantation biology, other transplant biology folks about inducing tolerance. He's very much involved in inducing heart allograft tolerance, as noted. And it's a well-supported, well-funded laboratory with NIH funding, as well as industry funding. It's a terrific opportunity, an exciting place to explore experimental design and methodologies, as noted here, a wide variety of experimental methodologies that are broadly applicable. Learning to write grants is very, very, very important. It's an important component of your education, and I know that there's a great emphasis on the part of the Department of Surgery to encourage folks to write grants before they get into their lab time, and while you're in your lab time, you need to develop that skill. Importantly, lots of surgery, large animals. When I did my lab work, one of the attractions to the David Sachs lab was that we got to do surgery on large animals, and surgeons like to operate. Next. And here's an example, Taylor and Maggie are doing some transplantation work. Surgeons like to operate, and it's nice to be in a lab where you can do some operating. Next. Device design and innovation. So we're working with the Wellman Center. In particular, this is work that Sergei Melnichuk is doing, looking at ferrous fluids for cardioscopy. Now, this would be a really transformational technology that would actually allow you to directly visualize the structures of the heart, the beating, working heart. You know, there's a great deal of interest these days in the treatment of structural heart disease through catheter-based technologies. The implantation of those valves, et cetera, is all dependent on fluoroscopy, et cetera. Imagine if you could do cardioscopy and actually look at and see the structures as you're implanting those devices. So Sergei's working on that with Gary Tierney. We've got some other activities that we're doing in collaboration with vascular surgery around device innovation in the Wellman labs. Next. And oh, by the way, Sergei's also doing some large animal work with Bob Levine on topics related to mitral regurgitation. So again, there are opportunities to do large animal preps, large animal work in our division. Next. So we also have active work in clinical trials. So we are now participants in the Cardiothoracic Surgical Trials Network, which is an NIH-supported multi-center effort to conduct prospective randomized trials in cardiothoracic surgery, and David D'Alessandro is the lead player for us in that. Next. You'll recognize this character who's also been involved in developing a prospective randomized trial just at our center. And we're working on collaborating with the Brigham as well to explore the use of novel anticoagulants as an alternative to Coumadin for patients who have perioperative atrial fibrillation. And Sean has done a great job with that. He's already had a publication of the design of this in the annals, and it's a terrific effort on his part. So kudos to Shauna. Next. There are a number of other clinical trials, many that we do along with anesthesia, really too numerous to count, but this should give you some sense of the kinds of things that are going on. Our feeling is that we should be entering every patient in some study. If they're agreeable to it, we should be studying what it is that we do. We want to make a contribution to the field, and this is all done, best done with involvement of all of you, residents, engagement, involvement in this. This is the way you learn to do science, and you learn to be a surgeon scientist, is by getting involved in this stuff at this point. Next. Our Outcomes Fellowship, I'm sorry that came out black, it's hard to see. We've got an Outcomes Fellowship that's been established. Every year there's one person who gets a master's, an MPH from the Harvard Chan School of Public Health. One year it's the Minahan Fellow, the next year it's the Martinetti Fellow. You can see that there have been a large number of abstracts and meeting presentations and manuscripts, over 50 manuscripts produced by those Outcomes Fellows. Next. So this gives you an idea of who the cast of characters are. So Jordan was the first Outcomes Fellow that we had. He did it just for 1 year, followed by Andrea, Phil. Naya Mohan is from Texas, and Stanley from Pittsburgh, from the Allegheny system. But we're certainly eager to have MGH residents involved in this Outcomes Fellowship. As you can see, a number of individuals, Phil and Andrea, are actually, their primary interest is in general thoracic, not in cardiac surgery, but we're delighted to have anybody involved because you learn the basic skills, and whether you're studying a cardiac problem or another problem, it's the same basic skill set. Next. Yeah, these all came out black. I'm sorry for that. So Jordan, I'll point out, he got 8 manuscripts out of that experience. It was just 1 year. He got an MPH in clinical effectiveness and some other activities during that time. Next. Andrea has published 25 publications out of her 2 years as an Outcomes Fellow, as well as being involved in the STS workforce and general thoracic surgery, etc. 19 meeting presentations. People all over the country and all over the world want to know about when Andrea is finishing, because they want to hire her onto their staff. Next. Phil also done a spectacular job. She's still got a number of manuscripts in the making. She only just finished a couple months ago, and of course there's a tail involved in this of manuscripts and publications that come out of that effort. Next. Naya, I should have pointed out that Phil got the Nina Starr Braunwald Thoracic Surgery Foundation Award. Naya got the same award, so we've had 2 in a row at the MGH, and I think that's probably a record. She's got a number of manuscripts and projects underway. She's in her 2nd year right now. And next is Stanley, who's only just started. And of course, the first year of that, much of the time is spent classroom commitments in the School of Public Health. So there's less probably manuscript production that way. Next. So we're excited to be expanding our research portfolio. We need your engagement and involvement, just as Yolanda said. Everybody's competing for your interest and your attention. You'll get great support, whether it's in our division or others, but we'd love to have you join the big red machine. Thanks.
Thank you so much, Tor. Really congratulations to your fellows and faculty members. I think it's pretty clear from the presentation so far. Often you have to look outside of surgery to solve surgical problems. And so that's really terrific. Just one quick question, Tor. If I was a trainee or a student, what is the best way to learn about the Big Red Machine? Is it the Saturday morning conferences or to email you? How do we do that?
Certainly, to email me is a great first step, and I'm happy to channel that in the appropriate direction if it goes to somebody other than me. Our didactic conferences, both cardiac and thoracic didactic conferences, are on Zoom. Anybody who wants to join those before the Department of Surgery rounds is certainly welcome.
Great, thank you. And thank you both for also finishing on time. Next, we'll hear from Dr. Eagleton for Division of Vascular Endovascular Surgery.
I'd like to thank Tor for setting us up. I think the importance of the Big Red Machine is to pump blood into the most important vascular vessels in the body, which are where we study these. So thanks, Tor, for setting us up for this. I'm going to highlight some of the areas of research in our division. I won't hit on everything. We have a lot going on. Almost everybody in our division is involved in some aspect of research. Can you move forward? One area we're not too involved in is basic and translational research move forward. And we're sort of in a rebuilding year for this, and we hope to have these opportunities available in the near future. The cornerstone of our research really is our clinical outcomes research, and this is based on several large national databases such as the Vascular Quality Initiative and our MGH data. An interesting area of research in vascular surgery is innovation in technology, and I'll touch on just a couple of projects our group is working on, but these aren't the only projects. There's something in an early stage called an endowire that Jahan Mohabali is working on, and then later stage developments in something called IOPS, which I'll show you examples of. And then we have a number of prospective clinical research projects that are ongoing. Some of these are industry-sponsored investigational device exemption trials, but many of them are physician-sponsored trials, such as our venous ultrasound study, Evolve Aorta, which I'll describe a little bit more. And then I'm going to actually ask Dr. Dua, a dynamic member of our division, to talk a little bit about a project she's just initiated, which is a multi-specialty project called looking at TEG in vascular surgery. Clinical outcomes research is really the cornerstone of our research, and this is directed by Mark Conrad, who's really in charge of this program, but it's supported by our entire faculty. Everybody's involved in some aspect of an outcomes research project. And we're also supported by a tremendous research staff who help us perform these projects. We do research in all areas of vascular disease. So if you have an interest in it, there's somebody in our group that's probably already looking at it, and we can get you involved in those projects. We're also interested in looking at outcomes in training and education in vascular training programs. Next slide. We've also been very successful at doing this. This is just looking at our 2019 to 2020 academic year. We had 11 residents and fellows that had research that led to an abstract presentation or publication. We present 31 presentations at our regional and national meetings, with several of these winning the research awards at several of these meetings. Next slide. We're also very prolific with, in a single year, nearly 40 manuscripts published or in pressed in high quality vascular surgery and surgery journals, as you can see here, just like every other division in the Department of Surgery. We host a summer pre-medical program, which is a lot of fun. This was initiated in 2009 for pre-medical students, kids who are at various ages in college that want to go to medical school. We take 4 students per year. They spend the summer with us. Last summer, we actually ran a successful program virtually, so they stayed at home, but still were able to participate in research. We're proud to boast that 100% of them ultimately matriculate into getting into medical school. And these students are mentored not just by the faculty, but the residents and fellows play a huge role in doing this. So if you're interested in mentoring, interested in education of the students who are interested in medicine, this is a great program to get involved in with us. Innovation in technology is a kind of an exciting area in vascular surgery where we spend a lot of our research efforts, and we're involved in all stages of development of different technologies. I'll highlight first Jahan Mohabali, who's really one of our new faculty in the last year, and he's been involved in the MESH program for the early development of an endovascular wire. And this is just a snapshot of the interest that he has. He wants to take an endovascular wire that we use, pass an electrical current through it, and change the properties of that wire. So early in a procedure, we might use a floppy hydrophilic wire to gain access to a vessel. He can then pass an electric current through it and change it to a stiff hydrophobic wire that we can then perform interventions over. And this helps us to cut down on the number of tools we use and the number of wire exchanges that we do through a procedure and make them easier. So I'm excited to see where he goes with this type of project. A later stage example is something that I've been involved with for about a decade, and this is called an intraoperative positioning system. We've taken a CT image and we're able to link this with the patient's anatomy. This is not a human here. You're looking at a porcine model where we've overlaid their aortic anatomy to a pig, exactly where that is in the pig. And then we've taken electromagnetically censored tools, catheters, wires, and sheets. We're able to track ourselves through those images and do procedures on these animals. And here you can see is accessing the right renal artery without using fluoroscopy at all. Next slide, please. We've taken another step further and we've linked this to a heads-up display and holographic imaging and linked this to patients. So you can see on the left, when you're looking at a patient, you can actually see their anatomy and where they are and where you're working within that patient exactly. And then we've linked this to more sophisticated tools. And on the right, you can see in a porcine model, again, we're using that holographic imaging and a heads-up display to actually place a fenestrated endograft and lining up a fenestration for the right renal artery and deploying this in that pig with it perfectly lining up without using fluoroscopy at all. And this would be a huge step forward for vascular surgery and cut down on our radiation exposure to both providers and patients. Next step. A number of prospective clinical research opportunities, and I'll just highlight a couple of them. We have a prospective multi-center trial that was started by one of our physicians, Sherry Scoville, who's looking at the ultrasound assessment of venous insufficiency. I run a program called Evolve Aorta, which is a prospective assessment of custom-made endografts to treat complex aortic disease. Next slide, a lot of opportunities within that program. There are really three arms, and we do some of this in conjunction with cardiac surgery. One arm is to look at the use of ascending aortic endografts to treat ascending aortic disease, arched endografts to treat aortic arch disease, and then branched and fenestrated endografts to treat thoracoabdominal aortic aneurysm disease. The beautiful thing about these prospective studies is if you have a specific question, we can modify the protocols in order to collect the data that you need. Right now, we have approximately 1,500 data points, including imaging and clinical outcomes that we prospectively collect and store in a database. Next slide. In addition to our own data, we've helped to organize what's called the U.S. Aortic Research Consortium, which are 10 sites across the country with similar research interests and similar types of programs. We've agreed on a set of data that we've pooled so that we can have a larger, robust outcomes analysis on these types of procedures. Currently, we have nearly 1,800 patients enrolled in the consortium. And when we're able to finally merge our data from the Cleveland Clinic, we'll have nearly 3,000 patients that have been treated with fenestrated and branched endografts, which will be the largest experience in the world. And our goal is to highlight our residents and fellows to identify projects that they can do that will represent the entire group. Next slide. I'm going to turn this over now to Dr. Dua, who's one of our dynamic new faculty members, and let her talk about a research project she's just initiated that's a multi-specialty project here at the Mass General. Anita?
Yes, thank you very much. I'm so excited to be talking to you all because I really need some people to come and help out with this fabulous project. Basically, what we're going to be looking at is utilizing TEG, which is thromboelastography, which is currently used a lot in trauma, and I'll explain about that in a moment, to predict arterial thromboembolic events in patients who are revascularized. So that's a mouthful, but essentially what I'm trying to figure out is in patients that have grafts that are put in their extremities because either they have a trauma or they have PAD and need to be revascularized, what makes these patients clot? Why do they clot and how can we stop that? And this is a project that really would be something that could be the basis of a variety of things that you could go forward to do. So it's not just a matter of, oh, I want to do vascular, I'm going to do this project to be in the vascular department. You could use this to ultimately go into any specialty after your training here. So it's a wonderful place to start that you could really use your general surgery training in conjunction with vascular to come up with a great idea. So next slide, please. Basically, what the issue is that we do a lot of extremity bypasses. We do it in trauma, as you know, we do it in plastics, we do it in vascular, of course. And a significant proportion of these patients within the first 30 days will clot that graft or that stent. And we've been blaming it for years and years on, oh, it's a technical deficiency. So that's going to be on your ab side, of course, that's on the B side as well. But the fact of the matter is there's actually a variety of other things that cause things to clot. For example, a patient's actual hematological state, whether or not they maybe have a cancer, there's a slew of things. And we don't really have a good way of figuring out what patients should get what anticoagulation. It doesn't really matter why they're hypercoagulable. The key is that you figure it out and that you're able to give them a blood thinner. Currently, we basically base all of our decision making on cardiac literature, which isn't really relevant for vascular disease. And what we're essentially doing is you've got 6 vascular surgeons, you got 6 different ways of giving blood thinners and not giving blood thinners, giving antiplatelets, not giving it, depending on the procedure. And I want to solve that problem with you. So basically, if we go to the next slide, the plan is that we're going to be using, next slide, please. Thank you. We're going to be using thromboelastography, which is TEG, which is a machine that basically takes blood and determines what the clotting profile is in a patient. So this is just an example of what a TEG profile would show. And I'll teach you all of this if you come to me. Basically, what you would do is you would take a patient's blood, run it on this machine, and you'd be able to figure out what type of anticoagulation or antiplatelet they need to ensure that their graft or stent doesn't clot, thereby preventing amputations. Next slide. This is just another example of that. Next slide. So the aim of our study is that we're going to be looking to see whether we can use TEG at point of care to determine what an anticoagulation regime should be for a patient based on their specific profile. And that's going to allow us to prevent amputations by preventing graft thrombosis. Next slide. The study plan, essentially at this point, it's going to be a 4-year study, but obviously within the 4 years, we're going to be publishing significantly. It's already funded. We're going to be doing this in joint with Dr. Salient from trauma and Dr. Eberlin from plastics, who are good friends of mine. And that means that anybody in any group can really join us. And we're going to be looking at a variety of patients over the course of this 3-year period, looking at their blood samples to determine the coagulation profiles. I would love for you to join us. And if you're available, please page me anytime. Almost everyone in the department has my phone number, and you can call and contact anytime. Thank you.
Thanks, Dr. Dua. I'd say if any of you are interested in vascular surgery research at all, reach out to any member of our division or just drop by our offices. We're happy to talk to you about the opportunities at any point. Thank you.
And I'd just like to just add that, remember, vascular surgery doesn't just have the 0-5 program. Matt and his group match one individual after full general surgery training. So it's not too late if you decide that you want to have a late interest in vascular surgery to move that direction.
It's never too late. So if any of you out there that are faculty and you want to switch over to vascular surgery, we'll consider taking you into our program too.
Great, wonderful. In the interest of time, I think next we'll hear from Dr. Tanabe on surgical oncology research.
Yeah, thanks, Eric. I'm going to take 10 minutes to show you some outstanding research laboratories involved in cancer research. Justin, next slide. Genevieve Bolin is the director of the Surgical Oncology Research Laboratories. Her lab is a translational research lab focused on melanoma and immuno-oncology, using cutting-edge technology to examine interactions between tumor and the immune microenvironment. Dr. Bolin's own work is in melanoma, but she's built a very large biospecimen repository to collect tumor, normal tissues, and blood from patients with many types of cancers before treatment, while on treatment, and after treatment. And I can only say, be it for pancreas cancer, colon cancer, liver cancer, melanoma, this bank is invaluable. Her team interrogates the specimens using a variety of sophisticated techniques to evaluate pathways involved in tumor biology, responses to therapy, and treatment toxicities. Regarding therapies, also, she's created what's known as the Therapeutic Intralesional Program, or TIP, which is an interdepartmental center. Next slide, please. Sarah Pei is a head and neck surgeon scientist, and is trained in immunology. Her lab focuses on understanding mechanisms of immune evasion utilized by human papillomavirus in head and neck cancers. The lab is very tightly linked to investigator-initiated clinical trials, wherein she tests novel therapies in preclinical models, and based on the results, she takes them into early phase clinical trials. So for example, her lab was one of the first to report on the PD-1, PD-L1 pathway activation in head and neck cancer patients. And that led to the first clinical trial giving anti-PD-1 to these patients. And that work was spearheaded by an ENT resident working in her lab on a T32 training grant. In her lab, an area of investigation focuses on enhancing response rates to immunotherapy, and she addresses this through the development of therapeutic HPV cancer vaccines, administration of epigenetic drugs to try to modify cancer cells to improve their recognition by the host immune system, identifying novel combinatory immune checkpoint therapies, and development of novel antibody peptide conjugates. And her lab also focuses on identifying biomarkers of response to immunotherapy. She's working on an innovative technology to enable biomarker testing in just FNA samples. She's got a very collaborative lab approach to scientific investigation, and she works closely with many investigators, both within and outside the MGH. Next slide, please. Shyamala Maheswaran works on technologies for isolation of CTCs, otherwise known as circulating tumor cells, their characterization and translational applications. Her team enriches CTCs from whole blood by removing the individual blood components, red cells, white cells, and platelets, using a microfluidic CTC chip. I see on the call here Mehmet Toner, who was instrumental in developing this chip, otherwise known as the iChip. CTCs are isolated using a very gentle approach, and therefore they're viable and intact, and they can be used for a lot of different applications. They can be stained for diagnostic purposes. They can be imaged by special high-resolution techniques. They can be cultured ex vivo for genotype-based drug sensitivity assays. They can be used to develop mouse models to study metastasis. And further, since they are enriched in solution, CTCs can be picked individually for single-cell analytics to determine cancer heterogeneity and how it evolves over time. Her team also develops RNA-based molecular signatures to monitor therapeutic responses in patients. So she leverages this technology to study fundamental, important questions of tumor biology, as well as participate in clinical studies, such as those involving detection of minimal residual disease, pancreas cancer, breast cancer, prostate cancer. Next slide. Motaz Kadan runs a clinical outcomes research group with a focus on GI cancers. His team has been quite successful and leverages several different databases for their work. He previously worked with dedicated research residents Naomi Sell and Grace Lee, in addition to other residents who weren't dedicated an assignment to his group. They each published extensively and presented to national societies. The second box reflects Motaz's interest in devising and running clinical trials. And one such trial is the pre-habilitation trial, for which he's currently PI, and for which Naomi plays an instrumental role. Naomi took the lead on many aspects of the trial, including helping with the design and write-up process, the IRB approval, and implementation of the day-to-day elements of patient enrollment. There's 2 HCC trials listed here as well, for which Motaz plays a key role. And clearly there's room for many, many more clinical trials, particularly surgical and multidisciplinary trials in his interest, HPV surgery. Motaz has a PhD and a track record of laboratory investigation. And so the third box represents his interest. His current laboratory research focuses on pancreatic cancer and modification of the tumor microenvironment to enhance the effect of pre-existing therapies. So for example, they're currently building an orthotopic pancreas cancer model to explore the potential radiosensitizing effect of losartan. And this was evaluated clinically in a phase 2 trial out of the MGH. Next slide, please. Sinhui Wang focuses on repurposing disulfiram for cancer treatment. Disulfiram, otherwise known as antabuse, is an FDA-approved drug for chronic alcoholism. And epidemiologic studies report that its use in alcoholism is associated with a reduction in mortality in cancer patients by 1/3 compared to patients who don't or stop taking it. So disulfiram is a chelator for copper. It forms complexes which target the stress response pathways and increases endoplasmic reticulum stress, and it results in an immunogenic cell death. And the fact that it's immunogenic is important. This is known as a hot death of cancer cells. So unlike regular apoptosis, which is primarily non-immunogenic, hot death of cancer cells induces an effective immune response against the dying or dead cancer cells through activation of the immune response through dendritic cells and T cells. Representative results are shown in the top right. So treatment of flank tumors with disulfiram, copper, and radiation induced complete regression in the mouse on the right compared to the control on the left. The mice have triple negative breast cancers. And of note, the irradiated tumor on the right, as well as the contralateral non-irradiated tumor, both regress because of a systemic immune response. Her lab also focuses on studies of CAR T-cell therapy to try to induce a hot cancer cell death using disulfiram, copper, and radiation. The representative results are shown in the bottom right, showing that the combination of CAR T cells with the disulfiram, copper, and radiation induced a complete regression of the triple negative breast cancer tumors, and 60% of the mice stayed tumor-free after tumor cell rechallenge due to the enhancement in vivo expansion and persistence of the CAR T cells. This is important work because, you know, CAR T cells have worked extraordinarily well for liquid tumors, but we still are challenged to make them effective in solid tumors. And then next slide, last and perhaps least is my laboratory, in which we work in 3 specific areas. The first is through genetic engineering of viruses to create oncolytic viruses. These viruses are engineered to replicate preferentially in and destroy cancer cells. And in doing so, they liberate progeny virion that can then infect adjacent cancer cells. We work in liver cancer and breast cancer models, and through our own translational work, we're running a phase 1 clinical trial in patients with liver cancers. The second focus is dissecting molecular mechanisms of liver fibrosis with an eye towards reversing fibrosis and prevention of HCC. We have been able to reverse cirrhosis successfully in animal models. And on the basis of our translational work, we conducted a multi-center clinical trial of erlotinib, which is an EGFR inhibitor, to reverse the process of cirrhosis. And the third focus is pancreatic cancer extracellular matrix with an eye towards examining the effects on treatments, opportunities for imaging, and opportunities to modulate the matrix to improve therapies. So the upper right shows a gross photo of an orthotopic mouse pancreatic cancer with the H&E shown just to the right of that, and staining for collagen with Sirius red to the right of that. We're able to molecularly image the presence of collagen with a specific probe developed by a collaborator shown just below the gross photo. We determined that in patients treated with pancreas cancer patients treated with neoadjuvant radiation therapy, the amount of collagen that develops in the pancreas as a result of the therapy correlates with survival. And our work also shows that we can image this non-invasively. And collagen accumulation was a better surrogate of response and survival than the pathologist's scoring of response. One of last year's chief residents, Derek Erstad, published this in Clinical Cancer Research. As you can see over the years, I've had really a wonderful opportunity to work with many surgery residents in my lab, and some are listed on the slide. So each of the investigators that I presented in this quick overview are surgeon scientists, and they do fantastic work. They're NIH funded. They would be superb mentors for you. Surgeon scientists remain the pinnacle of innovation. These investigators and I would be more than delighted to talk with any resident who would, at a minimum, like to learn a little bit more. Thanks very much, Eric.
Okay, Eric, should I jump right in?
Please do. Thank you.
I just want to make sure we try to stay on time. I want to just first, I can't help but be impressed with all the presentations so far. And I know we're not even halfway through we have another one next week. So it's really quite an impressive array of opportunities for the residents. Having said that, let me remind everyone that the gut is the seat of the soul, and all those blood vessels and things are designed to feed and keep the gut healthy. So let's focus where we should. I'm going to talk about the GI research opportunities as well as our thyroid cancer lab. It's obviously going to be a very brief overview, but there'll be a couple of key themes. Starting off with this T32 program that we have. This is a Harvard-wide program, and I'll point out a couple of things. It's available to residents, obviously at the MGH as well as elsewhere. There are 4 main tracks. You can see basic science, clinical research and outcomes, surgical technology and innovation, and surgical education. So there's really a broad array of research opportunities in basic, translational, clinical research. You have to apply for these slots. The call goes out each spring. We have a diverse faculty, and the main thing I want to emphasize, and I'll probably say this multiple times throughout, is that I'm a big believer in collaboration and to bring together surgeons with PhD scientists, with non-surgeon scientists, and I think they can be really great opportunities for residents to get involved and sort of bridge those collaborations. If you go to the next slide. The colorectal surgery group is really doing remarkably well. I think many of you know that there are regular meetings, not every week, but almost every week with the faculty and a bunch of fellows. And it's really been very successful so far and growing. There are multiple areas of interest related to palliative care, geriatric patient, pelvic floor disorders, cancer, IBD. There's use of a variety of sort of methods for clinical research with large data, local databases, and so forth. So if you have any interest, obviously, and I'll say this again, but please contact anybody, any of the individuals, faculty members that you know of, but also just come to me and I can discuss things with you and try to find you sort of the right place, the right person. If you can go on to the next. Nima Sadie is a PhD scientist who recently joined our division. He's interested in GI physiology and is one of the examples of somebody who we're sort of collaborating with and putting together clinical surgeons with Nima to study some key surgically related diseases. He has excellent funding and is involved in work related to obesity and diabetes. He does bariatric surgical procedures in small animals and then able to study the physiology very carefully, the molecular biology. He also uses models for IBD. So it's animals, it's in vitro. This gut on a chip is sort of state-of-the-art model for looking at gut physiology, and there are great opportunities there. If you go on to the next, is Lori Rami, is another PhD scientist who joined our division. She is a incredibly successful investigator and MGH research scholar. She's interested in bacteria. Obviously, that relates to a lot of surgical problems and surgical conditions. She uses novel anti-infective, so molecules that can fight bacterial infections that are not typical antibiotics. We're collaborating with Laurie on various things, including looking at the microbiome and the gut and related to various surgical models of infections. Next slide. The Pancreatic Biology Lab, I think everyone is familiar with, has been around for many years, run by Dr. Fernandez, and Andy Liss is the PhD scientist who has been there for many years. They work on a variety of areas related to pancreatic cancer, excuse me, epigenetic mechanisms, cellular heterogeneity in the stroma, the extracellular matrix, and the new grant that Andy got from the National Institute of Standards and Technology to develop new in vitro models of pancreatic cancer. So great opportunities there. Next slide. This is the Ferroni ×2 lab. That's Christina Ferroni and her father, Saldana Ferroni. Very well-funded laboratory looking at primarily immunotherapy for HPV cancers. That's for cholangiocarcinoma and pancreatic cancer. They use mouse models of these cancers and are extraordinarily productive. And again, another great opportunity, especially for the collaborative sort of model. Next slide. Then we have the Thyroid Cancer Lab that's run by Saray Parangi. Everyone knows Saray moved to Newton Wellesley as the chief, but has maintained her lab, and in fact has just a recent big grant that she received to look at hurdle cell carcinoma. She uses mouse models of thyroid cancer and looking at various genetic pathways and developing new therapeutics. Next slide. Finally, my lab looks at the gut, the host microbial interface. Some people may know I've worked on this molecule called intestinal alkaline phosphatase, IAP, for many years. It's an anti-inflammatory. It regulates the microbiome and also a positive regulator of the gut barrier. Relates to a lot of different diseases. We use mouse models as well as in vitro systems, including the gut on the chip, and collaborating with some of the PhD scientists that I've already mentioned, looking at various conditions like IBD, metabolic syndrome, the gut mucosal failure and critical illness, and aging. The picture shown is of our last opportunity to have the annual barbecue for my lab, which hopefully we can do again, maybe this next summer, if not 2022. And I'll just finish up. This was my first slide, but I just want to emphasize a couple of points. This T32 program is a great opportunity for residents. It's nice on your CV. It provides salary support and also other sort of training opportunities outside of the exact lab. Again, multiple areas from basic science to bioengineering type stuff, innovation to education. We have a diverse faculty. We're looking for residents to apply for the T32 slots, obviously, and to put into labs or opportunities where we can combine surgeons and non-surgeon MDs or PhDs. In some cases, some of the junior faculty will be combined with senior faculty. So various co-mentoring relationships, which I think can really be of great benefit to the residents. You don't have to be in the T32 to work in any of our GI or the thyroid cancer lab, but it is a potential opportunity. Just please contact, again, you can contact any of us individually. If you just email me, I'm happy to sit down and try to point people in the right direction. Thanks.
Great, thank you so much, Rich. I think that's really a great overview of the work going on in your group, spanning clinical to fundamental research. I know we're coming up on the end of our meeting. I'm going to post all the presenters and their emails for those of you that may not be on partners email for the students if you want to reach out. And finally, we'll hear from Dr. Lubitz and Chang about health services research at the Department of Surgery.
Great, Justin, you can skip to the third slide, please. So I've been charged with, you can go back to the prior slide, sorry, Justin, thanks, with discussing the health services research going on in the division. I would say that MGH historically has been known for its basic science and innovation. However, we have a growing group of outstanding researchers across the departments, and I just want to highlight a few of them. I apologize if I left anyone out. This is a broad, as you can see from this quote from the AHRQ, health services research covers a wide breadth of research and methodology. But these are some of the folks that I've been working with and trying to really build strong collaborative groups, including we're meeting on Fridays now to go over potential HSR grants to be submitted, as well as David and I working across town with Zara Cooper and Jim Rodriguez at the BI, as well as David Chang, and developing a potential new T32 submission. So that will be forthcoming, looking on surgical disparities. I'll let David mention that a little bit. So the first group I want to highlight is welcome back Dr. Griggs, as well as Dr. Kelleher and Peter Masiakos, who are really involved in quite a bit of different work, including equity and appropriateness of care in pediatric surgery. I know that Cornelia has been involved in this EPSN, which is looking at improvement in various pediatric surgical issues that need a higher degree of, this is a cross consortium so that you can develop a patient group that's large enough to make meaningful research and outcomes, as well as COSMIC, which is a childhood obesity to deliver high quality metabolic and bariatric surgery for adolescents. Next slide, please. I keep trying to move the slide, sorry. We all know Dr. Hutter. He had, in addition to his letters behind his name, he now has an MBA as well. But he does a ton of work with disparities as well as using national databases for quality improvement. But really prominent in his research program is a PCORI funded grant looking at the development of PROMs nationally for metabolic and bariatric surgery. Getting a PCORI grant is quite a feat, so congratulations to Matt for that. Next slide, please. The next group, the transplantation group, has been quite busy, and I know that these may be highlighted in their own divisions, but I just wanted to show that Leanne Daggerford, Nahel Elias, and Heidi Ye have been doing outstanding work. I know that looking at medication and wellness interventions, so more implementation aims and potential clinical trial that Leanne is planning on moving forward with recovery intervention for patients undergoing liver transplant. Disparities research Heidi's been working on for transplant allocation, as well as marginal organ utilization. And I know Nahel has done a ton of work. I just added this on late last night, but he's been looking at the willingness of transplant candidates to accept Hep C positive deceased donor organs, as well as graft survival and in hepatitis B positive donors and recipients. So a lot of great work out of the transplant unit that can be considered HSR research. Next. I know that Christy's work was highlighted under the colorectal division, but I just wanted to highlight our relationship with Ariadne Labs. Mary Brindle is a pediatric surgeon who will be joining us eventually. She's out of the country currently, secondary to the pandemic, but she's the new director. She took over for Alex Haynes as the director of safe surgery, I believe is the name at Ariadne, and both Dr. Panda and Dr. Cawley are associate faculty, as well as I am actually, over at Ariadne Labs, working on a cadre of various projects, and currently Trey Synard is the research fellow. So a lot of great work from that group, and I'm sure either Panda or Christy would be happy to discuss the possibilities over at Ariadne Labs, and I'm sure you could reach out to either one of them. Next slide, please. And then my own work. I wanted to highlight that none of my work would be done without all the other members of the endocrine surgery unit. Without further ado, a couple of grants, it's harder talking about myself, I guess. You've heard me give grand rounds, but my R01, which is now in R37, is looking at using microsimulation modeling at the natural history for thyroid nodule for treatment optimization. I recently, fortunately, got an American Cancer Society grant. Oh, I'm echoing. For the development of a thyroid cancer specific patient-reported outcome measure, an index. We also, Rashri, Dr. Gartland and I have been running over 24 institutions across the world, actually, trying to gather data for patients who were postponed for surgery during the pandemic and following them for untoward outcomes down the road. That is aptly called the Lemonade study. And then Dr. Stephen has been in charge of our CESCOP, which is the endocrine surgery equivalent of NSQIP, for multiple QI projects and initiatives. She's involved in numerous fellows and residents and had numerous publications. Obviously, Dr. Parangi and Roy, who is maybe highlighted in a different section, are proliferative as well with their research. Just not enough time to talk all about it today. Next slide. And this is my own lab. And the one thing I would just say is that I'm sure there are tons of residents and fellows and PhDs and postdocs that contributed to all of those research projects. And we don't have enough time. But the one thing I would say before I let David take over is that I'm more than happy to talk to each and every one of you about potential research time, or projects within the time you're during your clinical years. That's one benefit of doing HSR work. There's my email there. And David, please. Without further ado.
All right, Justin, go ahead. Next slide. Just want to echo what Kiri has mentioned, what HSR is all about. I just want to mention that HSR, in practical terms, is really about quality improvement. And to echo what Dr. Colson had mentioned earlier, quality is actually considered one of the top 10 causes, if not top 5 causes of death currently, as people actually try to measure it. So it's a huge problem in our healthcare system, and MGH actually played a significant role in the history of quality improvement. Behind me is the Codman chart. I'm in the Codman Center office, and Dr. Codman is considered the father of quality improvement, and he was an MGH surgeon in 1914. Next slide. And a natural extension from quality improvement is this issue of healthcare disparity, which is an important concept within sort of the quality improvement world. And my take on quality healthcare disparity is healthcare disparity. A lot of people talk about sort of systemic bias and structural racism. I just want to highlight the fact that the root cause of all systemic bias and structural racism is essentially bad research. Bad research contributes to policies that then contribute to systemic bias. I was interviewed by NPR in 2018 for one of my papers, and one of the quotes they quoted from me was this concept that flawed science could hurt more people than flawed care. And I think that's an important point to keep in mind, that a lot of time when we focus on disparity, we focus on the care delivery process, when in fact there might be a bigger problem in the science where the science is actually flawed. Next slide. I have two key guiding principles. I focus on introducing new concepts, and I want to really focus on identifying modifiable risk factors, i.e. focusing on the systems and social determinants and not on the individual patients. And I try not to focus on the stats, because I believe at the end of the day, it's about driving change. Complicated stats are not going to convince people to change. People who will believe you based on simple stats. People who won't believe you won't actually be moved by complicated stats. They'll probably be turned off. So I try to focus on simple, clear, and new messages. And the way we do this is by bringing collaborators from outside of surgery. And this brings up an issue of what's normality bias and the importance of coming up with alternative interpretations. Next slide. One of the new concepts that we introduced recently is this concept of underemployment. Unemployment is probably non-existent within surgery, but we notice that a lot of the anecdotes from female surgeons are very consistent with the concept of underemployment. And so we actually have been working with a labor economist who was at Harvard and now is at the University of Chicago. And we recently published a paper in the Annals of Surgery looking at this issue of underemployment with my colleague, Casey Kelleher, this issue of invisible underemployment to the issue of gender inequality in surgery. It was actually interviewed and quoted in Forbes magazine. And what it does is it directs the attention to the systems and not individual surgeons, again, focusing on the systems and not the individuals. A classic example of underemployment is the college graduates who work in Starbucks. No one would blame the person for not getting a better job. People will naturally focus on the system. And that's the value of concepts like underemployment. Next slide. Also looked at this issue of concordance of patients and provider, a very hot topic when people talk about disparity. However, we are concerned that what it does is focus the attention again on the individual physicians and the patient. And while we worry that the emphasis on patient-physician concordance may actually lead to segregations, Sahel and Numa Perez both have actually done projects with me where we looked at the issues of segregations. According to our lit review, it's probably one of the first paper looking at segregation, patient segregation within the scientific literature. Both of them actually back-to-back have won national meetings, resident competitions. Sahel won in the first year, Numa won in the second year. SBAS is the Society of Black Academic Surgeons. So we're very proud to sort of introduce this concept. As an alternative to the concept of concordance between physicians and patients, Dr. Chalawa Hosseini and I have developed a grant focusing instead on the organizations, on the diversity of organizations, focusing on the systems and not on individual providers. We believe that minority physicians should not be solely tasked with the responsibility to deliver care to non-white patients. That should be the goal of everyone. The impact of minority physicians is to change the organizational culture so that everyone is going to become more culturally sensitive. Then it doesn't matter who sees the patients. So our grant is focusing on that effect, where we look at the changes in organizations as it becomes more diverse. Another study, another sort of concept we looked at is this concept of really thinking about heterogeneity of treatment effect. I want to highlight this paper in JAMA Surgery. Sahel was the first author on this. Next slide, where again, we looked at the issue of breast cancer. Everyone probably knows that the breast cancer guideline was raised to 50 because most people get it in the 60s. Very few people get it under 50. It turns out, if anyone ever bothered to break out the data by race, next slide, it turns out every racial groups, Asian, Black, Hispanic, all peak in the 40s. The only group that peaked in the 60s were actually the whites. It's an important concept where a lot of time we look at the data, and what we don't realize is there's quite a bit of heterogeneity in terms of the data. And what you might actually come up with very different conclusions. You've actually sort of like consider the heterogeneity in the data. Next slide. Just want to tout this paper in particular. Among the many papers and resins we work with, this one particularly has garnered quite a bit of attention. Altmetric score there, 288, actually puts us in the top 1% globally in terms of sort of altmetric measures. It was interviewed, we actually received quite a bit of press attention, including the local NPR. And so we're quite proud of this. Sahel was the lead author on this. Next slide. Lastly, really worry about this concept of normality bias in interpretation. And I brought this up with the disparity grant rounds the other day. And I'm concerned a lot of time when people look at differences, they naturally jump to the conclusion that certain group is the correct group or the normal group. For example, when you see a slide like this, where you have the white patient prevalence on top, Black, Asian, Hispanic on the bottom, people naturally think that it's the problem is underdiagnosis or undertreatment in minority. So a few weeks ago, they were talking about this issue of opiate prescriptions. This is actually a slide from ADHD prevalence. So again, the paper concluded that there might be underdiagnosis among minority patients. However, graphs like this only shows that there's difference. It doesn't actually prove that there's underdiagnosis. It could very well be overdiagnosis. And the fact that we're often not willing to consider that there could be a problem in the white populations concerns me, because it suggests that we often take the white population as the norm and then benchmark every other population against it. That could be a problem. And then the way to do this is, again, not from complicated stats, is by really coming up with a multidisciplinary group, looking at the same data and actually come up with different interpretations. I actually presented this slide to a bunch of students, white students from Europe, and most of them says the conclusion is underdiagnosis. I presented to the Latino Medical Students Association the same day in the afternoon. They actually says it could be overdiagnosis. Again, different people look at the same data, come up with different interpretation. This is, I think, next sort of frontier in disparity research, really sort of alternative interpretation of the same data. Next slide. My guiding principle in looking at research and working on research is, I really believe research is really one of the best form of leadership training. At the end of the day, what a leader does is coming up with new ideas, getting people excited, rallying a group, putting together a group, measuring the impact, building a team, communicating your results. That's what a leader does. It's different from what a manager does. Manager sort of execute on the status quo. Leader take people in a new direction. At the end of the day, good research gives you that. It gives you the idea how to come up with idea, how to advocate for it. Research, I truly believe, is one of the best form of leadership training. Next slide. Again, it comes from sort of learning how to break down problem into manageable pieces. Next slide. Develop a plan and roadmap. Next slide. Identify key personnel to build a team. Next slide. Learning to measure the impact of your work objectively, not like Thoracic, where they never measure the impact of their work. Next slide. And learn to communicate results and advocate for your idea for change. That's what leadership does, and that's what a good research training does, and that's my philosophy and guiding philosophy in working with people on research. Next slide. And so this, to that extent, we focus on bringing in collaborators. We're working very closely with the Brigham on their Center for Surgery and Public Health. Some of our Syria project, we're working with a sociologist at Harvard. We're working with labor economists. We're working with qualitative researcher. It is about collaborations, and I think that's a message being echoed by a lot of other speakers. Good research involves multidisciplinary research, and I think that's about collaborators, and that's an important thing to keep in mind. Next slide. So at the end of the day, why focus on HSR? I really believe what we do is learning to train future leaders of healthcare who can fix our problems at the systems level and not just at the individual level. Next slide. And that's it. Thank you.
Great. Thank you so much, Carrie and David. I think for many of the trainees and students, the only one message I have is, being at MGH, we have, just embarrassment of riches. We've seen several examples of just phenomenal research, both translational, fundamental, basic, and clinical, that try not to be paralyzed by inaction of indecision. I think if you see a problem that speaks to you, you're interested in it, align it with a mentor that works in that area, and just start the conversation. I've in the chat, I've put down all the emails of the presenters today. So I really hope that from this week and next week, you get energized to reach out and start to build your careers. Keith, do you have any comments?
No, just a great job by all the presenters. It's so exciting, all the options. I know for the junior residents and students, it may seem overwhelming, but just take a deep breath and think about the area that interests you, and there's plenty of people here willing to help. So a great job, and we'll see you next week with another set of 6 fabulous presentations thank you everyone for staying so closely on time.
Great. Thank you, everybody.